All right, so good afternoon, everybody. My name is John Prisvalis. I'm the third-year resident in sports and exercise medicine here at U of T. And my topic for the journal club today is the clinical examination of suspected meniscal tears. So I decided to choose this topic because of some recent cases that have come up in clinic and just overall the difficulty in diagnosing these cases for both myself as a sort of junior sports medicine doctor and more experienced physicians have echoed sort of the same sentiment that it can be a difficult diagnosis in times. The structure of my presentation, so I'm going to start with sort of the anatomy and a brief overview of the clinical background of meniscus tears, the history, the physical examination, but then really the meat and potatoes of my presentation are the two journal articles that look at meniscus tears, their sensitivity, specificity, and comparison to both MRI and arthroscopy. And then we have an interesting case round at the end as well, unrelated to this. So the anatomy review, there are two menisci in each knee, the medial and lateral. They're placed between the femoral condyles and tibial plateaus. They're crescent-shaped and they're made of fibrocartilage, and their function is to dissipate the loading forces, so axial loading or twisting forces through the knee. And they also give you some stability and rotation. So this is a diagram. They're sort of wedge-shaped, so larger at their periphery, and then they get more narrow as you go inside. And if you notice, the medial meniscus is also in closer, communicates more closely with the medial collateral ligament, and that's one of the factors that increases the risk for medial meniscus injury compared to the lateral side, because when you injure your MCL, you can also tear off a piece of the medial meniscus there. The blood supply comes from the geniculate arteries, and there's more blood supply to the sort of periphery, so those tend to heal better than tears closer to the inside that aren't as well vascularized. So there's sort of two divisions to the mechanisms of injury. There's acute traumatic tears and there's degenerative tears. With the traumatic tears, it's typically a planting and twisting mechanism of injury. And then the incidence in studies has been reported around 10 to 15% of all knee injuries that come into a clinic. The degenerative tears happen over time, and those are more vague symptoms, so they can describe a vague pain, discomfort, maybe some mechanical symptoms as well, and it's really difficult to estimate the incidence of these because of the association with osteoarthritis and no clear mechanism of injury with those cases. So those can be definitely more difficult to diagnose. Briefly, the history, the pain can be localized medially, laterally, or sometimes people just point and say deep in the knee. There can be a mild effusion, swelling associated with it, and mechanical symptoms, so catching, locking, and giving out. On physical examination, of course, you're going to assess them for other injuries, but the meniscus-specific tests are the ones I've listed here. So on inspection, you're looking for an effusion. When you're palpating, you're feeling for medial or lateral joint line tenderness. On range of motion, typically there's pain at end range of motion, and that's usually more inflection. Or if there's sometimes even a hard block or restriction in range of motion on exam. The most common special tests I've seen performed in the clinic setting are the McMurray's, Thessaly's, and Apley's tests. There's a whole list of other tests that were listed in one of the articles, and we won't get too bogged down in those, but I just wanted to go through the more common ones for the physical exam. So I have a few videos here. So that's McMurray's. This one's the Thessaly's test. And in medical school, we were all taught the McMurray's test for meniscus, but sort of more recent literature has suggests that maybe the last two, the Thessaly's and the Apley's, are perhaps better tests for meniscus. That's basically what you're doing there. So about 30 degrees of knee flexion, and then you're holding their hands while they rotate. And this is Apley's.
Different, like when you were looking this stuff up, did you notice that there was a difference in how people described like what a positive test was?
Yeah, definitely. So some will say more mechanical symptoms like a clunking sensation or a clicking sensation, and then some will say pain as well. So I think as long as you're clear in your notes when you say that, that's important. And I don't know if it makes a difference in terms of sensitivity for meniscus injury because different articles describe them differently. So it's like you're not dealing with apples and apples. It's tough. Okay, so those are the tests there. So my question for this presentation was, how good are our clinical examination techniques at detecting a meniscus tear? The first article was titled History, Clinical Findings, and MRI Imaging and Arthroscopic Correlation Meniscal Lesions. It's out of a group from Turkey, and it was published in the Journal of Knee Surgery, Sports Traumatology, and Arthroscopy in 2011. The aim of the study was to correlate exactly what they said, the history, clinical examination, MRI, and arthroscopy in diagnosing meniscal tears to look at the reliability and value of an experienced surgeon in the clinical decision making. So the structure of the study was as such. So they started with 270 patients that were admitted to this clinic with knee symptoms. And then somebody assessed them. They made an initial diagnosis of a meniscal tear. So basically everybody with a non-meniscal tear diagnosis was excluded. And then from that meniscus tear group, patients with joint line tenderness, and or mechanical symptoms and an injury in the last 12 months were included, and people who didn't have those symptoms were not included. So you're looking at traumatic tears. And then basically anybody with degenerative changes, loose bodies, prior arthroscopy, and non-operative treatment were excluded. So then you had 30 patients that didn't get excluded because of those, and that was your final study population.
I don't understand why they excluded like the non-operative treatment patients. Isn't that a big, large number of patients that they're missing out on?
Yeah, so I agree. And there were a lot of issues with the sort of selection. So like you're looking at a very high pretest probability for meniscus tests, right? So it's not like you're just getting people with vague knee symptoms that come into our clinics. It's people who somebody already says this person probably has a meniscus tear, plus mechanical symptoms possibly, and then they don't have the most likely other diagnoses that go along with it. So I thought that was pretty specific selection. And the non-operative treatment, I guess the argument could be made that, you know, the rest of the group might or might not have had some treatment, so they wanted like a clean sample, and that might have confounded things. So they didn't really mention it specifically, but that was my sort of guess. And they underwent clinical examination by 4 people. So sort of increasing levels of experience from an experienced knee surgeon to a specialist in general orthopedics, a senior resident, which I assume means at least 5 years of experience, and a 4th-year resident. And their clinical examination was defined as these 7 tests. So medial and lateral joint line tenderness, McMurray's, Apley's, Steinman 1 test, Payer's test, Childress sign, and Edge's test. And a positive exam was defined as 2 or more positive tests here. And so this is the results. So they kind of focused on the last column, which is accuracy, and I'll talk a little bit about accuracy as a statistic in a couple slides. In our previous lectures, we talked a lot about sensitivity, specificity, positive predictive value, negative predictive value, so I won't get too into that, but you can see the statistics here. I think the trend was more evident with medial meniscal tears in general, which are shown to be easier to diagnose in the literature rather than lateral meniscus tears. As you can see, when it comes to the accuracy, there's a clear trend with the medial meniscus tears, but the lateral, they're all at around 80 to 83%. And those trends kind of follow in the other columns as well. So they're showing a clear experience effect in detecting meniscus tears. And that was sort of their main result that they said. The diagnostic accuracy of medial meniscal tears based on clinical examination performed by an experienced surgeon exceeded the accuracy of an MRI. So they got an MRI accuracy of 83% and the experienced surgeon was 93%. And that level increased with level of experience. So they concluded that using an MRI as a routine diagnostic supplement was unnecessary. A thorough clinical assessment can provide enough information for the surgeon to make a decision with regards to treatment. They said if the experienced surgeon says it's probably a meniscus tear, we don't have to do an MRI. And so I just wanted to take a break here because Dr. Dilworth asked me to talk about a statistic here. And we talked about most of the other ones, but accuracy was a sort of new one that we didn't discuss previously. And it's defined as the closeness of a measure to its true value. So it's a pretty intuitive statistic. How it's calculated is the true positive rate plus the true negative rate over the total population. And in our standard 2x2 table here, so we're looking at the green boxes, the true positives and the true negatives over the total population. In this case, our gold standard would be arthroscopy, and our test outcome would either be the clinical assessment maneuvers or MRI testing on the left. And then you get an accuracy statistic. So when it came to this article, I thought what it did well was it reinforced the importance of accurate clinical examination with an increasing trend towards more technological and bedside ultrasound and all those types of things. I mean, there is the fear that clinical exam will go to the wayside, but this article said that, it's even better than MRI with an experienced surgeon, so we should really be sticking to clinical examination. I like the study in that it demonstrated an increased accuracy with the clinical experience, which I thought was a nice touch to the study. With an experienced surgeon, obviously better able to detect these meniscal tears than a 4th-year resident, so definitely a practice effect to it. And the statistics were pretty straightforward, easy to understand and interpret, and didn't get too bogged down in analysis and that type of thing. I thought in terms of limitations, there was a high pretest probability for meniscus tear in this sample they chose. So they, like we talked about, they chose a very high pretest probability. The population was a small sample, only 30 people. And I mean, when we read studies, we try to think, would this population apply to me? Is this what the population I'm seeing in my clinic? And I would probably say no, because we see undifferentiated knee pain, and that's not what this sample was. They didn't mention any sort of blinding in their procedures, in their methods, so I think there's a high potential for bias in results. It was the same surgeon performing the examination as who did the initial assessment of the meniscal injury, so definitely some bias there, and he was also the one doing the arthroscopy. And then when it came to the accuracy, they did say that the surgeon was better than MRI, but they didn't really do a calculation of statistical significance for that. So was that 10% difference within the realm that we would expect with chance, or was that really truly a statistically significant result? The second article was the clinical diagnosis of meniscal tear is not easy, reliability of 2 clinical meniscal tests and magnetic resonance imaging. This was a group out of Italy, and it was published in the Journal of Immunopathology and Pharmacology, and this was also in 2011. And the purpose of this study was to evaluate the reliability of McMurray's test, Apley's test, and MRI for meniscal tears. And so they started with 160 patients after an acute injury. So again, traumatic meniscal tears, not looking at the degenerative meniscal tears. Their primary exclusion criteria were another diagnosis of osteoarthritis, rheumatoid arthritis, psoriasis, articular fractures, surgery, ACL tear, or mechanical locking. And 51 patients were excluded that way. And then the secondary exclusion criteria were discordance in clinical examination. So basically, there were 2 examiners that examined them, and if they didn't agree on positive or negative tests, then those patients were excluded. So you got 102 patients at the end who did not meet any of those exclusion criteria and who the examiners agreed were either positive or negative on their meniscus tests. So all those patients, so the whole 102, went on to receive arthroscopies. And out of those 102 arthroscopies, there were 74 meniscal tears. They subcategorized them into 55 medial, 12 lateral, and 7 had both medial and lateral tears. And these were their results. So for the McMurray group, we'll go to the sensitivity and specificity statistics, so around 80% for both. And with Apley's, the sensitivity was slightly higher at around 84%, but the specificity was a lot lower at near 70%. At the end of the day, the accuracy was roughly similar, so around 80% for both of them. And pretty similar in terms of their positive predictive value and negative predictive value. So not too much difference between the 2 tests here. And then they went on to basically combine the tests. So when they say MM and AP, so that's McMurray's and Apley's tests. And then concordance means that basically those, like it's an and, so McMurray and Apley's, so either those 2 were positive or those 2 were negative. And so if they were concordant, it gave you a lower sensitivity, 75%, and a lower specificity at 64%. But then if you use the or condition, so if either McMurray's or Apley's were positive, then the sensitivity was higher. But surprisingly, also the specificity was higher as well, which kind of surprised me. So I thought that was interesting that they combined them like that. And so those results, 93% and around a 90% specificity, are pretty good results for a test. So they're saying that if you do a clinical examination and either one of those tests are positive, then those would be your statistics, or at least the ones they got in the study. So they went on to conclude that history, clinical examination, and MRI should be combined to come up with an accurate diagnosis, but it doesn't negate the risk of negative arthroscopy. So they still had around 25% of the arthroscopies they did were negative. They didn't find any evidence of meniscal tear on arthroscopy, so that was pretty surprising. The things I liked about this article were that they looked at the tests separately rather than the first article, which kind of grouped them all together and said, if you have any 2 positives on these tests, then that's a positive exam. This one broke it down, so into the McMurray's test and Apley's test specifically, and they also looked at them in combination, which I thought was a nice touch. They blinded the examiners in this study, so it wasn't the same examiner looking at doing the clinical examinations as the original intake physical exam. And the person who read the MRI results was also blinded to the study. And they also tried to correlate the length of the meniscal tear to the clinical examination findings. They didn't find an association, but I thought that was interesting as well. The limitations of this study was that they were looking at a relatively homogeneous population. It was all post-traumatic meniscal tears, and they controlled for a lot of the commonly comorbid conditions. So typically a younger population without any evidence of osteoarthritis, degenerative changes, no ACL tears. So a lot of those confounding factors that we often see in our sports injuries that are multi-traumas. And they mentioned that the examiners performed 6 meniscus tests in their method section, but then the analysis was only performed on 2. And they didn't mention why they excluded those other tests and why they weren't included in the analysis. So I assume that it didn't really conform to their hypothesis, which, I mean, it would have been nice to include in the results, but I guess they wanted to get what they found. And then I wanted to add in this last slide about MRI imaging. So the first study, the sensitivity of MRI in detecting meniscal tears was 95% for medial, 67% for lateral. The specificity was 60 and 88, respectively. And then the accuracy was 88%, respectively. The second study didn't break it down into medial and lateral meniscus tears, and then it just came up with an overall, which was 73% sensitivity and 85% specificity. So roughly similar to what we're seeing if you sort of average them out from the first study. And then I asked Dr. Bleakney, one of the musculoskeletal radiologists here, Mount Sinai Hospital, for our sort of statistics at our institution where we send a lot of our imaging. And he said that the sensitivity for medial was 90 to 95%, and specificity was similar. Sensitivity for lateral was 85 to 90%. So slightly lower than medial, but that's sort of what the evidence shows. The studies were 5 years ago, and he did say that there were advances in imaging in terms of the power of the magnets and sort of technical improvements. So that sort of speaks to the increased sensitivity and specificity, but I think it's also a specialized center, which also helps. The second study stated that they were sort of more rural and that a lot of their machines were older and known to be less sensitive. So, I mean, that could have confounded their findings as well. And
it shows an interesting journal to publish it into.
Yeah, exactly. Not exactly your, yeah. My sort of reflection on these articles was that the clinical examination sort of falls into the art of medicine a lot. In medical school, a lot of what we learn is the science of medicine, and you learn a lot of things, and you memorize them, and then you regurgitate them, and that's what you're tested on. The clinical exam is different. And I kind of reflected on this. We had some teaching sessions last week with some pre-clerks, and watching them perform the physical exams compared to experienced sports medicine physicians or orthopedic surgeons. I mean, it's totally different, and it's a practice effect. Like you have to do these things over and over to know what you're looking for, to get a feel for it, to get a feel for a positive test, and that's what these kind of articles told me, and something that I've noticed in my training as well. So, did you have any questions or concerns?